Good afternoon and welcome to the Health Technology Wales Health Economics training session in Value in Health Week. My name is Dee Puckett. I'm Head of Health and Care Engagement at Life Sciences Hub Wales, and I'm the Senior Lead for Value-Based Healthcare and Industry. The Life Sciences Hub Wales is a wholly owned subsidiary of Welsh Government, and our role is to work with industry and across the health and social care landscape to identify the key challenges and opportunities for innovation, co-creation and collaboration projects which support better outcomes and experiences of citizens across Wales, enable better utilisation of resources and to encourage economic growth. We're really pleased to be hosting and developing Value in Health Week session in partnership with National Value in Health team this week. And we're especially pleased to be continuing to work with Health Technology Wales to deliver this really important training opportunity today. It's the first time we've done it virtually, but this has actually enabled us to enable so many more of you to join us. We've had over 180 registrations right the way across health, industry and academia. So welcome to the session. It's the third session of the week. There's still plenty of opportunity for you to register for other sessions during the week, so they're still open if you'd like to. So without further delay, I'll hand over to Dewi in the Health Technology Wales team and we'll get this training started. Thank you very much.
Thank you, Dee. Prynhawn da. Good afternoon, everyone. Welcome to the webinar. As Dee said, thank you for joining us. My name's Dewi. I'm the Communications Officer here at Health Technology Wales. And I say here, we've been working from home since March, so we're pleased to see so many of you join us for this series of free virtual events. Before we get going, I should start with some brief housekeeping. So today's session is called Health Economics 101, and it should last around 90 minutes. To start, I'll give a brief overview of Health Technology Wales, who we are, and what we do, and then I'll hand over to Matthew, our principal researcher, to deliver the webinar. This should take around 60 minutes, and in that time, not to patronise you, I'll promise, all you'll see will be the slides on the screen. You won't see our lovely faces until the Q&A section that follows the presentation. So questions can be submitted as we go along, and they'll appear in the questions chat box so that we address the questions that you collectively as the audience want answering the most. We're asking you to give a thumbs up to your favourite questions. You can do that by hovering over the questions and a thumbs up icon should appear for you, and we'll prioritise answering those questions first later on. So let's get going. Health Technology Wales was set up by ministerial recommendation in November 2017. We're funded by the Welsh Government, we're hosted by Valindra University NHS Trust, and in more normal times we're located at the Life Sciences Hub in Cardiff Bay. Our remit is to provide a national approach to the identification, appraisal and adoption of non-medicine health technologies into health and care settings in Wales. Now, that's a very broad church and it covers a lot, everything from robotic surgery to stress balls to medical devices, psychological therapies, telemonitoring, rehabilitation and so on. And anyone can submit a topic to Health Technology Wales to appraise. That's whether you're a patient, a member of the public, a healthcare professional, a care commissioner, industry, and that list also goes on and on. If there's enough evidence for the submission, it will be added to our work programme. And we'll assess the technology for its clinical and cost effectiveness, which is probably what has brought most of you here today. So the end of this process, should a topic make its way the whole way through, sees us issue independent authoritative guidance based on the best available evidence and expertise, and then that's used to inform commissioning by NHS Wales, and decision makers are better able to make evidence-informed decisions. And I won't steal any more of Matthew's thunder. That probably sets us up nicely for the start of the webinar. But just a quick reminder before we get going, if you're on social media over the next hour, check out Health Technology Wales on Twitter and tag us in your posts. Now I'll hand over to Matthew and we'll start the presentation.
Thank you very much, Dewi. I've not got control of the presentation as it stands. Right. We all see the presentation. Okay, so thank you very much. As Dewi said, this is our Introduction to Health Economics 101, sort of crash course in health economics, if you will. The sort of thing that I guess in an ideal world you might be spending a whole day learning about. But we're going to try and run through it in an hour. So as I said, it will be a bit of a crash course, high level for the most part. It is HE 101. So it's going to cover the basics for the most part, and we're going to have a little bit of a discussion about some of the methods that are used in health economics and why it's useful, why it's important in decision making. So just to start with a little bit of a brief overview of Health Technology Wales. So as Dewi mentioned, Health Technology Wales is an appraisal body really. It's set up by the Welsh Government with sort of three core aims: to identify, appraise and adopt new technologies in health and care settings in the NHS Wales. And really, I guess our focus today, with it being HE 101, is going to be primarily on that appraisal function part of it, which is part of the appraisal process that we use when we're assessing technologies. So ultimately, the aim will be to assess the evidence on a particular technology, both in terms of its clinical effectiveness and its cost effectiveness, and then to determine whether that technology should be adopted in NHS Wales or not. And yeah, we're going to focus on the cost effectiveness side of it today, but that's not the only factor that's considered when making an appraisal of a technology. It's multifaceted, as that diagram indicates. So, and there's obviously there's the evidence around the clinical effectiveness, the cost effectiveness. There's also patient issues that you might need to consider as well that might not be captured in the evidence base. So yeah, it's part of a wider package. Now, just as a little bit of context and a bit more background for you, to date we have carried out appraisals for about 21 technologies, I think, if the slide's up to date. And based on that, we've made 15 pieces of guidance for technologies. So in some cases, there's not always enough evidence to proceed to guidance, but where there is, we do so. And yeah, you can see that we've made quite a few different types of recommendations, or things that have been adopted in a selective or more routine way, and see it's roughly about 50-50 as to whether things have got adopted or not thus far. And yeah, we get our topic referrals from a wide range of sources. So there's the NHS, there's industry, Welsh Government, but you see the vast majority thus far have come from the NHS and industry. And ultimately, our aim is to encourage the adoption of things that have been proven to be clinically and cost effective, which is where health economics comes in. So I'm just going to give you a very brief overview about, in broad terms, what health economics is, and almost as importantly, what it isn't, because I think there's often a lot of myths, I suppose, about what health economics is about. So the reason that we consider health economics is because the NHS faces a limited budget, a fixed budget. So what that implies is that when you decide to spend money on a particular thing, it also means that you're spending less on something else. And so the focus of health economics is about figuring out what gives you the most benefit, spending in the new area, as compared to the spending that you're losing elsewhere. So really, we talk about costs a lot, but it's not really about costs in pounds and pence that we're interested in. It's about the opportunity cost. So it's what you could be doing with that money if you weren't spending on the particular thing that you're talking about. So it's really that, as that diagram indicates, it's kind of saying you introduce a new thing into the budget, it necessitates taking something else out of the budget. And yeah, that's really the focus of what we do in health economics. So if you'll forgive the possibly bitter rant of a health economist, just to kind of labour that point a bit and do a bit of myth busting, what it's not about is saving money and spending less. I think that's possibly the misconception about health economics, is that we're interested in things that are cheaper, effectively, than what's currently done. Perhaps because cost effective itself as a term is, I guess, used somewhat synonymously with cheaper, but when a health economist says something is cost effective, they really mean it more specifically than that. It's not just about cost. So yeah, as I say, it's not about saving money and spending less, because in a sense there's not really such a thing as saving money in the NHS budget, because it stays pretty flat over time. The NHS budget, it goes up a bit, but along with everything else, but in terms of a percentage of GDP, it's pretty consistent. So really what that means is when you decide to spend less on something, you're just going to spend money elsewhere. It's always budget is always largely the same. So in a sense, health economists are not really concerned with minimizing costs. We're concerned with maximizing benefits. It's getting the most value, to, I suppose, to use the key term of this week, really. It's about getting the most value from the money that you spend on the NHS budget. So what that means is that it is possible for things that are very costly to be cost effective. It's possible, and it happens quite frequently, that things that are very costly are cost effective if they are more effective than the available treatments. It all depends on how much more effective and how much more costly, of course, but it's certainly possible for very expensive things to be cost effective. And on the flip side of that, just because something's cheaper doesn't necessarily mean it's cost effective. It has to be either as effective or more effective than what's currently used. As I said, their effectiveness matters too. I mean, most of our time in health economic modelling and things is actually spent on the effectiveness side of things, probably more so than the cost side of things. So in terms of the types of economic analyses, if you've had any familiarity with economic analyses, you might have come across some of these terms. So I just thought it might be useful to give a bit of a glossary. And in broad terms, what you're looking at is kind of 4 types of cost effectiveness analyses. The first 4 are largely variations on cost effectiveness analyses, with the key thing being how they're measuring effectiveness. The last one is simply a cost minimization analysis, which is largely just looking at costs, or it's entirely looking at costs, and it's just looking at which one is the cheapest. It's not really considering effectiveness. In fact, it makes the assumption that the things that you're looking at are equally effective. So the cost effectiveness analysis, that's one that's measuring effectiveness in some kind of non-monetary term. So often a technology or drug that improves survival, for instance, you might look at how much it costs for each extra life year that you gain by using that new drug or technology. Cost utility analysis is the one that we're sort of most interested in, and probably the one that's really going to be the majority of this session is kind of going to focus on the cost utility analysis. It's a more specific type of cost effectiveness analysis that uses QALYS as the outcome measure. So QALYS are quality adjusted life years, and we'll go into that a bit more in a later slide. And cost consequence analysis, it uses effectiveness in more I don't know, specific to the particular intervention terms. So it might be sort of a cost per exacerbation for something like that, or cost per exacerbation avoided with respiratory disease, something along those lines. And cost benefit analysis, that expresses the benefits as well as the costs in monetary terms. So that I'd say the ones you don't see that one so much, to be honest, in health economics. The ones that you primarily see are cost utility analyses, cost consequence analyses, and cost minimization analyses, as well as just the cost effectiveness analyses with cost per life year gained. So yeah, just a little overview of the different types of economic analyses. And as I said, in my view, the economist sort of view of the matter would be that cost utility analysis is the gold standard. It's the best way to truly establish whether something is cost effective or not. We'll go into that a little bit more as we progress through the slides, hopefully that will be clear as to why that is the case. But in truth, while that is the kind of academic view of what is the best way of truly demonstrating something's cost effective, if you were to kind of allow for a bit of pragmatism, and owing to the fact that, so if any of the attendees today are manufacturers and are thinking that they need some health economics to support their case, cost utility analyses would be the most expensive of the options to sort of get someone to build you a cost utility analysis. So it's sometimes worth thinking about whether it's cheaper, more pragmatic, more practical to actually get something else developed, and whether that could still demonstrate the value that you need to demonstrate. So, as I say, that's academic view would always be the cost utility analysis is the best possible way of doing it. But if you allow for a little bit of pragmatism, there are alternatives, but you just have to be careful. So it depends on what value the particular technology is going to offer. But as an example, a procedure, so for instance, I think this is based on a VR product. A VR product as a distraction therapy may allow someone to have something performed under local anaesthetic that would normally be performed under a general anaesthetic. So therefore, you could just look at the cost savings from that, because the savings from doing something under local anaesthetic rather general anaesthetic is going to vastly outweigh the cost of the VR equipment, as a for instance. So in that kind of situation, you could argue that a cost minimization analysis is sufficient to make the case economically. But as I say, I think whenever you go down that road, the sort of contentious issue is going to be whether things are truly equivalent in effectiveness terms. So they may be that they're broadly equivalent, but actually if there are little differences, you may get picked up on that. So moving on to measuring effectiveness and costs. So in terms of our effectiveness measure, the key difficulty and why cost utility analyses is typically preferred is that we're not really measuring like for like. When we're trying to allocate resources as best we can across all of the NHS, that means that we need something that can uniformly measure the benefit of technologies across the NHS. And as that table is showing, so for instance, a surgical intervention, say a sort of minimally invasive surgery intervention instead of a typical open surgery approach, that might decrease operative morbidity and complications. It might cost £10,000 extra to do that procedure that way. A new diagnostic test, very topical with the COVID stuff going on, but you might have better sensitivity and specificity as a result of using that test, and it might cost £400 and so on. So the palliative care is obviously, that's looking at quality of life, really just improving quality of life at someone's end of life, and that might cost £50 a week. You might have a telemonitoring device that might pick up problems or deterioration quicker, such as say a diabetes glucose monitoring device, and that might cost £100 for each device that you give out. And so then what you could see hopefully is that in terms of cost, you can obviously always compare things in terms of their cost, but in terms of their benefit, when they're all doing things that are very different, it's very hard to say whether one is worth paying more for than another. So what we really need, as I said at the start there, is a uniform measure of benefit that can be used across all interventions within the NHS. Because only that way they can then really assess the relative value of each intervention. So QALYs, or quality adjusted life years, are the way that we do that. So you may well have come across QALYs before. It is kind of a HE buzz term that gets thrown around quite a lot. So as I say, the core aspect to it, what it's really offering is that it is a uniform measure. And what it does is it combines quantity of life and quality of life into a single measure. So you're looking at someone's survival in terms of life years, and then you're weighting that survival by the quality of life they have whilst in that particular health state. A quality of life is scored typically between 0 and 1, where 1 would be perfect health and 0 would be death. 1 is perfect health. Seldom actually seen is anyone with perfect health. Generally, just say even the general population tends to drift around 0.89, something like that, I think, off the top of my head. But it's a theoretical perfect health state. And what you have is, in this particular scenario, it's kind of showing that equality is equality, as people like to say in health economics. And what that means is it could be 10 years at perfect health, it could be 20 years at half health, but it's in both cases it's going to equal 10 QALYs. So it's looking at, there's two ways that something could be better. It could be better in terms of your quality of life, or it could be better in terms of your survival. And it's just putting the two together for quality of life. I'm going to go into a little bit more detail on actually how quality of life is measured, because there are lots of different quality of life measurement tools that are used. But going back to the idea that what we're after here, because we're looking across all of the NHS, all of the interventions that could be used, what we're really after is a generic measure of quality of life. So for instance, there's one for cancer called, I think it's called QALY CLC 30, something like that. But that is obviously very specific to cancer. So it has lots of questions within it that are all related to cancer. And it'll give you a score between 0 and 1, but it'll be for cancer. And then when you're trying to compare that, as we're doing indirectly in health economics, compare that against any other intervention that could be done in the NHS, it doesn't really work, because obviously it only applies to people with cancer. So that's why in health economics we always favour generic measures of quality of life, and the one that is the preferred measure based on a preference from NICE, National Institute of Health and Care Excellence, is EQ5D. So that's QALY 5 dimensions, and this is an example of how that works. It's a very simple questionnaire, just 5 dimensions, which is mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And then within each one of those 5 domains, there's 3 levels that someone can tick, as you can see there, whether they have no problems, whether they have some problems, or if they have extreme problems. And so someone would fill in that questionnaire, and each one of those things, based on previous studies carried out in the UK, there'll be weightings assigned to each one of those selections that have been made. So you apply the weightings to each one of those domains, and you come up with a overall quality of life score, which will be somewhere between 0 and 1. So in practice, what you might end up with is something like this, which shows how someone's quality of life changes over time. So in this case, if you imagine there's a new treatment, say for instance that we're looking at the blue line representing radiotherapy, and the purple line represents chemotherapy and radiotherapy. What you might see is there's initially a loss in quality of life because you've added chemotherapy to the radiotherapy, and that's going to have side effects. So initially the quality of life might be a bit lower, but then over time the quality of life and the survival would be better because of the extra efficacy of adding in the chemotherapy. So that whole purple section that's been shaded, that's the QALYs that have been gained, and you're kind of trading that off against the very small, comparatively, initial loss in quality of life. So in terms of actually doing that for different economic models, it's easier said than done in some cases. There are definitely examples where it's relatively straightforward, such as the example I just gave, where you're looking at 2 different interventions that's relatively easy to see how you might convert the type of outcomes that, say, a clinical trial that's looking at chemotherapy and radiotherapy. That's going to measure things like overall survival, progression-free survival, and it's quite simple really to convert that into the sort of QALY outcomes that we're interested in. But it's not always so easily done. It's certainly easier for those intervention types, much harder, say, for something like a diagnostic type of intervention. But the principle is always the same. What we're aiming to do is to link the sort of key clinical data that we've got from clinical trials and convert that into data that can be useful for QALYs. So as an example of a tricky case, so where you have got a diagnostic accuracy as your key clinical data, so something like sensitivity and specificity, which again, I'm hopefully not teaching you something you don't already know, but say sensitivity is looking at what's the probability of getting a positive result if you actually have the disease, and specificity is what's the probability of having a negative result if you don't have the disease. So that's very topical, I suppose, based on COVID discussions at the moment. But in terms of converting that into something that's useful for an economic analysis, we need to say improvements in sensitivity, so i.e. picking up more people that actually have the disease. We can link that to improvements in health by diagnosing something faster. So as for instance, since it is so topical, if you have a new COVID test that has a sensitivity of 95% rather than 70%, that increases the likelihood that you're going to pick up someone that has the disease. By picking it up sooner, you might be able to manage the patient faster, get them the care they need, and that could lead to improvements ultimately in that patient's chances of surviving and their quality of life. So that's the sort of thing that we're looking to do in health economics. We're very patient oriented in our outcome. It's always taking those kind of clinical improvements and things like sensitivity and specificity and trying to link it to the patient. How does it affect the patient? What does that mean for the patient's management and the patient's quality of life and the potential survival chances? Likewise, improvements in specificity, really, for the most part, that has cost consequences. It might have, occasionally has quality consequences as well, but it's primarily a cost driver. So again, I guess just to use it as a topical example, but a new COVID test that improves specificity from, say, 90% to 100%, meaning that would mean that there's no longer going to be any possibility of false positives. If someone gets a positive COVID test at the moment, it may mean for that particular person that they have to isolate. Their quality of life probably would go down as a result of that. So you possibly could link it to quality of life in this case. In future, if we do get some sort of treatment, some kind of management that might be used for someone with COVID, it might also mean unnecessarily treating someone. So again, it's the same sort of principle. It's trying to link those key clinical data to outcomes that ultimately matter to the patient. That's the key. And to consider the other side of the equation, the costs side of things, is, to be honest, a lot more straightforward than the effectiveness side of things. There's a lot more. I think people instinctively have a better understanding of what costs are considered. It's probably largely what you would expect it to be. The only one thing to really note is that we take the perspective of the NHS, or strictly speaking, the NHS and personal social services. And what that means is that some of the things that people often bring up when talking about health economics as being potential benefits are not actually routinely considered in economic evaluations. So often you get someone say, this intervention means that patients can get back to work. That's good for the economy, so that needs to be considered in an economic analysis. It might be true that it gets people to work, but it doesn't is not going to be considered in most economic evaluations, because we're only looking at costs that are relevant to the NHS. So those sort of productivity losses, as they're termed there, are not actually routinely considered. And likewise, costs incurred by patients or carers, or costs incurred by other government departments, are not routinely considered as well. I'll go back. Perhaps I'll touch more on this perspective issue in a few slides' time when we talk about the threshold. But again, it really goes back to the core principle of what we're doing in health economics, which is really maximising the benefits that can be gained from the NHS budget. So it doesn't really make sense to start considering cost savings that might occur in other budgets, because that's not affecting the NHS budget. So there are caveats to this. This is kind of a broad sweeping statement, and in practice, there are instances where, say, you might look at the health economic implications of social care interventions, for instance, in which case it obviously makes sense to consider such costs as those due to time off work and things of that nature. So there are caveats and exceptional circumstances, but I'd say the vast majority of UK evaluations take the NHS perspective. So in terms of what is covered, as I said, it's probably things that you would largely expect to be covered. It's the cost of the medical procedures or investigations, so any diagnostic tests or imaging that might be done, any surgical procedures, the costs associated with any new equipment or devices. So the actual, I don't know, say if you're looking at robotic surgery, I think as Dewi mentioned earlier, you'd have to consider the cost of the equipment of that robot in your evaluation. The cost of staff time, so GP visits, consultation specialist, nurse visits, all of those would be considered as well as just the length of stay in hospital. And of course, I mean, our focus at Health Technology Wales is non-medicines, so we don't tend to consider medication costs all that much. We only really consider them in the sense that they might be offset. They might be a consequence of the thing that we're looking at. Might be that it either increases or reduces medication costs later on in someone's life. And just to give you a couple of examples of the sort of typical cost sources that we're looking at. So these are the things that are already in use. I mean, if we're talking about doing the cost effectiveness of a new technology, a new device, which invariably we are, then the cost of that new technology, that new device, that's probably going to need to be costed separately as a sort of bespoke exercise of actually bottom-up costing approach, we might call that, just trying to figure out all of the various elements that might be involved in that new technology, that new device, and working out the costs for it. But in terms of things that are already done within the NHS, in terms of procedures or investigations, our primary source for that is NHS reference costs, which is a sort of massive Excel database which is published annually by the Department of Health. And just to give you some examples, partly maybe to give you a bit of take-home value potentially, because some of these are things that come up. The cost of an MRI scan, for instance, covering one area without contrast would be about 143 quid, and that would vary. So that one's looking at one area without contrast. There's probably about 8 to 10 different ones that are variations on one area, two area, three areas, with and without contrast, 19 years and over or 18 years and younger. There's lots of variability in there, but it's giving you broad costs for doing things such as that. I've given you an expensive example as well, which is one that's relevant to a assessment that we did of a blood stem cell transplant for MS, which is quite expensive at 16,768. But and there are other costs to that as well. There'd also be costs associated with harvesting before you actually get to that stage. But maybe a nice example of, I suppose, of what I said at the start, because that is expensive, but actually that our economic analyses showed that treatment to be cost effective. So perhaps a good indication of things being expensive but still cost effective, because it works, because it really works in comparison to what else is used. And also, just as something that does come up quite a lot, is what's the average cost of someone staying in hospital for one day? Our best estimate of that is probably the excess day costs from NHS reference costs, which is about £431. So for each additional day that someone spends in hospital, that would be the cost. So yeah, as I said, NHS reference cost is a very, very useful source of costs associated with common procedures. In terms of other staff costs, so as I mentioned earlier, the GP visit, we tend to use unit cost of health and social care, which is something that's published annually by the PSSRU, which is the Personal Services Social Research Unit. And so from there, as an example, it's the classic example of a GP visit, which they've estimated based on study. On average, a GP consultation lasts 9.22 minutes, and they've costed that at £39. So importantly, that's not just the cost of the GP's time itself. That'll also be accounting for overheads, and maybe even the GP's qualification and training costs. Yeah, so it's not just looking at the staff time. I only say that because we've had a lot, often when you present that cost, GPs will say, I don't earn that much, but it's not just looking at their salary, it is considering other things as well. Medication costs tend to come from NHS drug tariff where possible, or the electronic market information tool, which basically gives average costs that are paid in hospitals, or the British National Formulary if we have to rely on sort of the list price for drugs. As I say, I mean, drugs costs are not really our primary concern at Health Technology Wales, because our focus is non-medicines. So in terms of how we actually generate our estimates of cost and effectiveness, we use economic models. And really, I suppose, just to give a bit of background on why we do that, because I suppose you could argue that in an ideal world, maybe you wouldn't use a model, but in truth, the data that we have available to us is not really sufficient to be able to say with any certainty what the QALYs and total costs would be, just purely based on the results of a trial. That's partly because trials are often short term, so we're often interested in things, the long-term consequences for patients, and most trials at best have sort of 5-year outcomes, 10-year outcomes maybe, but the vast majority we're often looking at 2 or 3 year outcomes from a lot of trials. And so it's partly a means of extrapolating beyond the trial period to cover a longer time period. But it's also just because there's that combination of different things that we're interested in that are not all going to be covered in one study. So it's taking things from different sources and combining them together in a model, especially in relation to on the effectiveness side of things. As I mentioned, that quality of life. You might have survival outcomes, for instance, from a clinical trial, but they might not have measured quality of life. So you're going to have to source your quality of life estimates from elsewhere, a study that's actually measured quality of life in patients of that type and apply that to it. It might not have captured anything about resource use, for instance. You might have to estimate that separately and then apply your costs, your unit costs to it, your cost per GP visit or whatever it is, apply all that to it as well. It might also be that you might have strong evidence from an RCT of sort of relative effectiveness, but that baseline risk is missing, and you might have to source that from elsewhere as well, that kind of epidemiological data. So it's really a cost effectiveness model is really a way of synthesizing and kind of combining a lot of the available evidence in order to generate the outcomes that we're interested in, total costs and QALYs. And just to go through we're not going to go, this is HE 101, so we're not going to go into the models in a great deal of detail. We're going to keep it pretty light touch, but just to give you a sort of brief overview. This is one type of model. a fairly basic one, as you can see, a decision tree model. So we got two interventions, intervention A and intervention B. Intervention B is better in effectiveness terms than intervention A because it's got 50% people well, whereas intervention A gives you 30% of people that are well. So what we're doing in HE is we've got cost and QALYs associated with being either sick or well. So say it's 0.8 QALYs for being well and 0.2 for being sick. And likewise, there might be some costs associated with being sick or well as the costs of the interventions itself. So you've got difference in costs and you've got difference in QALYs that will be driven by the effectiveness of each of those interventions. So as you can see down the bottom, you've got intervention A, say, has an expected cost of 6,800, and that's based on the fact that 30% are going to be well and 70% are going to be sick. And it's taking the costs of each of those and kind of calculate a weighted average of it. And likewise, you're doing the same for QALYs and for intervention B as well as intervention A. So that's one type of model. It can obviously be a lot more sophisticated than that. You might have numerous kind of offsets. You might well have it branching off again from well and sick, and you can kind of keep doing that. Well, for as many as you want, really, but until it gets unmanageable, which they do get unmanageable quite quickly. And they're also primarily good for capturing short-term outcomes, because otherwise you just have to repeat that same decision tree over and over again. Say you're checking for a recurrence or something, you'd have to keep doing that decision tree every year or something like that. So it's good for short-term outcomes, but it's not so good for longer-term outcomes. So to do your more longer-term outcomes, maybe more chronic conditions and things of that nature, we tend to use a different type of economic model, a Markov model, which I'm going to go on to explain in a moment. But just to set down on this time horizon thing, so we tend to, our guiding principle in economics is that what we need to do is we need to cover the period over which outcomes could be reasonably expected to differ between the intervention and comparator. In practice, that typically means that you need a lifetime approach. Not always, but that's broadly what you need. So I'll try to think of a good example. Again, maybe if I go back to that chemotherapy, radiotherapy thing, it might be that that QALY outcome I showed that improves over time. You need to make sure that you capture all of that gain. So I think in that diagram, you probably had an improvement in survival of, say, 10 years or something like that. So you'll need to make sure that your time horizon captures that 10 years. Otherwise, you're not going to accurately capture the benefit of the new treatment. So that's kind of the guiding principle of it, is that you have to try and capture the period where things are likely to differ. And the other thing to say about that, again, possibly not something to go into too much detail on, given that it's HE 101, but future costs and benefits are discounted as standard by 3.5% per year. So that means what you're doing is you're saying that people will value their future costs and effects less than current costs and effects. So effectively, you could pay £100 today, or you could pay £100 5 years from now. You're likely to be much more bothered by paying £100 today than you would be from paying it 5 years from now, rather. So it's trying to assign a value for that. It's saying that you value future costs and benefits less than you value current costs and benefits. So yeah, as I said, so when we're looking at more longer term impact, we tend to use Markov models. I mean, it's not exclusively the case that we use this, but I think by giving you the two, I think you're getting a reasonable overview of the two that are most frequently used in economic analyses. So yeah, a Markov model is a means for estimating disease progression over a long term, very good for chronic conditions. And how it works is you divide a health condition up into various health states. So in this case, we've kept it simple with well, sick and dead. And essentially at each each cycle that we're going to go through each time at a certain time interval, say every month or every year, you're going to look at how many people are likely to transition from one of those health states to another. So we call that chance of that happening, we call that the transition probability. So as an example, say we've got initially 1,000 people starting in the well state, maybe after a successful operation perhaps. What's the chances of them becoming sick again, some sort of recurrence of the disease, the chances of them dying, and the chances of them dying is also going to be influenced by whether they're well or sick. So if you say at the start 1,000 people are in the well state, if you move it on to a second cycle, say this is 1 year later, you might say 150 of the people that were initially well are now sick, and 50 of the people that were initially well are now dead. And I mean, we could just go on and on like this, but you could see that in the next cycle, 20% of the people that are currently sick are going to be dead, and another 15% of the people that are well are going to be sick. And it just keeps going like that. It's until you've reached the sort of end of your time horizon. So partly because I want to demystify health economics to some extent, I thought I'd show you what that really looks like in real life, which is really a pretty dull spreadsheet. But that's largely what we're dealing with in health economics. We're often doing these spreadsheets, and you can see how people in the wells, basically if 1,000 people start off in the well state, as you go down each year, that's just decreasing year on year, and more people are progressively getting sick, and then dying. And as I mentioned, costs and QALYs, it's doing the same thing that was done in that first decision tree example. There'll be cost and quality of life benefits associated with being well or sick, and that's being captured as well. So that what you ultimately are going to end up with are some cost effectiveness results. So in terms of how we interpret cost effectiveness results, how we assess value, if you will, what you're going to end up with is a situation where if that y-axis represents changing in cost, so the difference in cost between the new intervention and the old one, and the x-axis represents change in effectiveness, the difference in effectiveness between the new intervention and the old one, then you can kind of divide things into 4 quadrants. So you might have a situation where something is less effective but more costly, and in which case it's kind of no-brainer territory that that's a bad idea as something to do. It's less effective and it's costing you more. It's not something you're going to want to do. And on the flip side of that, you might have something that's more effective and less costly. And again, it's kind of no-brainer territory. It's obviously that's going to be something you want to do. And we kind of call those two things. We call something that's more effective and less costly, we tend to call that dominant. Or something that's less effective and more costly, you'd call that dominated. But what you're left with is these two sort of awkward grey areas where something's either less effective but less costly, or more effective and more costly. And I guess there's no prizes for guessing that. I don't know. The majority of things that we look at tend to end up in that top right box, where they are offering some improvement in effectiveness, but it comes at a cost. So that's where the ICER comes in, and again, it's possibly a buzzword that you might have heard about if you have any familiarity of health economics. So it's the incremental cost effectiveness ratio, and what that's doing is it's dividing the difference in costs by the difference in QALYs. So it's looking at the difference between two interventions, intervention A and intervention B in this case, and the difference in effectiveness, and dividing the one by the other, so that you're going to end up with a cost per QALY. And that ICER result would then be compared against a willingness to pay threshold, as it's called, which is effectively the amount that the decision maker is willing to pay for one QALY. There's probably, I mean, that setting of the threshold what it really represents goes back to the principle of HE again, but it's the opportunity cost, because I guess you could think of it as the kind of going rate for a QALY. So if I just show you the next slide, so there's two thresholds in the as recommended by NICE, which is pretty much what all of the UK HTA bodies tend to subscribe to. So the key one is the £20,000 per QALY threshold. Anything less than £20,000 per QALY is going to be cost effective. So in those areas that were previously grey, if something's producing one extra QALY at £20,000, then it's going to be cost effective. If it's above 20,000, it's, for the most part, it's normally not cost effective. There's kind of this awkwardness about the 30,000, which overcomplicates things a little bit, but says strictly speaking, something between 20 and 30 could potentially be cost effective if there's reason to think that the economic analysis has perhaps underestimated the benefits. Essentially, it gives a little bit of wiggle room, but perhaps not quite as much wiggle room as it's sometimes misinterpreted to give. It's for the most part £20,000 is the real threshold, and 30,000 is more for exceptional circumstances, really. There are also further exceptional circumstances where you might have something like end of life care, where anything over £50,000 per QALY, under £50,000 per QALY rather, would be cost effective. So there are a couple of caveats, but broadly speaking, these are the thresholds that we're using to say, is it cost effective or not? And broadly speaking, it's £20,000 per QALY that matters. But certainly in the vast majority of scenarios, anything above 30,000 wouldn't be considered cost effective. And yeah, to go back on what I just said a moment ago about, I mean, this, some people get this and some people don't. So I guess there's two ways of looking at the threshold. It's either something that you just accept it as the willingness to pay, that's what the threshold is. But what it really is trying to represent is, as I said, it's the opportunity cost idea. So it's really the going rate for a QALY in the NHS. So what it's saying is, if the thing that you're looking at produces a QALY at less than £20,000 per QALY, that's less than the going rate for a QALY in the NHS. So it's a good thing. It's something that that you'd want to adopt. Whereas if it's above that level, then effectively you're saying, well, we think actually we can get better value by spending our money elsewhere. So that's kind of the core idea behind the threshold. And just to kind of further that example a little bit in terms of the results that we get. So yeah, just again, taking our generic example of intervention A and intervention B, you might have a situation where intervention B is more costly by £1,200 in this case, and it produces extra QALYs, 0.12 QALYs, say, over that could be over the patient's expected lifetime. And in that case, you're going to end up with a cost per QALY, the ICER value of £10,000. So it's going to, you could say that intervention B is going to provide one additional QALY in comparison to intervention A at a cost of £10,000. As you can see on that little graph there, that puts you in that top right quadrant, but crucially below the acceptability line of the threshold. So effectively, in this case, you'd conclude that intervention B is cost effective. There's a little bit more to it than that, though, in that we don't tend to rely purely on a point estimate of cost effectiveness. We instead appreciate that there's normally a lot of uncertainty, and we do our best to capture that uncertainty and also look at to what extent it really matters in terms of the conclusion of the analysis. And we do that through sensitivity analyses. And you see, I was trying to be very deliberate in the way that I said that then, because in truth, economic analyses is a type of decision analyses. So it's not really the case that we're estimating some true value of cost effectiveness and that it's in its own right useful. It's really only useful for a decision. So the crucial thing is, do these sort of areas of uncertainty alter the decision that would be made? And that's what we're trying to look at with our sensitivity analyses. Because it may be that that's an aspect is very uncertain. Say to go back to the idea of a COVID test, say with sensitivity, you may not really know with any certainty whether sensitivity is 80% or 70%. It might be that it could be anywhere between those two values, but that doesn't necessarily mean that you couldn't recommend that it's used, because it's about how much does it matter if it's 70% or 80%? Would it still be more cost effective if it was the lower end of that spectrum? And if it is, then you can sort of conclude that it's cost effective. So that's really what we're trying to do with sensitivity analyses. We're trying to figure out what the area of uncertainties are, pull them apart, and have a look at whether it's actually going to impact the results. So as I say, I think we obviously, as part of Health Technology Wales, when we make these decisions based on evidence, our decision makers in our panels, they would certainly consider the kind of sensitivity analyses, that exploration of uncertainty, to be very important, because it does affect the sort of confidence that they can have in the conclusions that they're drawing. The other thing it does is it sometimes is very useful as an indicator for the areas where additional research is needed. So you might, for instance, show that quality of life is a very important aspect in the economic analysis, and that maybe there's a lot of uncertainty around quality of life. So say someone in the untreated versus treated health state maybe is saying that on average they have a quality of life gain of 0.3, say, but there's a bit of uncertainty around that, and it could range from 0.1 to 0.4, and the economic analysis is showing that if it's 0.1, it's no longer cost effective. That's going to be a pretty strong indicator that what you're going to need to do to really convince a decision maker is firm up that estimate of quality of life, because otherwise there's always going to be that uncertainty, and in that case they'd say the uncertainty matters, so that means that additional research on it would be very valuable. So yeah, without wishing to labour the point too much, but there are, broadly speaking, there are two main types of sensitivity analyses. There are others, but these are the main two. There's a deterministic sensitivity analysis, often called one-way or sometimes two-way sensitivity analyses. And in that case, what you're doing is you're changing one of the inputs in your model, and you're taking a look at what the new result is. And yeah, so the things I've just been describing, essentially, some things like that, where you might change the sensitivity, you try lowering the sensitivity, see whether it has an impact on the overall results. As I say, I guess the tendency with that one is to focus on areas where there is a large amount of uncertainty. If, for instance, if you know the device cost is £100 and it's definitely £100, there's not really a lot of value in doing a lot of different scenarios where you change the device cost, because it's a known quantity. So it's really more for those aspects where there is a large amount of uncertainty and where it has the potential to really change the conclusions of the analysis. The other type of sensitivity analyses, which again I'm going to give you a very broad overview, because it's probably something that's better explained in a kind of, I don't know, HE 102, I guess, something a bit more in depth than the HE 101, but it's effectively what we're doing in probabilistic sensitivity analysis is assigning distributions to each input to represent the overall uncertainty around it. So as an example, in clinical trials, if clinical trials have looked at the effectiveness of something, so say a cancer treatment that improves overall survival, it might represent that as sort of a hazard ratio or relative risk, and it might say that value might be sort of 1 point, that's probably 0.8, let's go 0.8, and then you'll have some uncertainty around that, a 95% confidence interval. Maybe it'll range from 0.75 to 0.9, something like that. what we're doing in probabilistic sensitivity analysis is we're generating a distribution based on that confidence interval. And then we basically rerun the model multiple times. And each time we're running it, we're randomly picking a value from that distribution around that input. And as well as doing it for that input, we're also doing it for every other input in the model. So every input that's in the model will have some kind of estimated variance around its mean value, and you do that across all of them multiple times, and what you'll end up with is something like that scatter plot to the right that's showing all of the difference. Each one of those blue dots is a run of the economic model, so there's probably about 10,000 runs of the economic model in that diagram, and each time it's recording the result and then plotting it on the graph. And you see in that case where it's crossed, in this particular instance, it's crossed that's the threshold that we discussed earlier. So that's the cost effectiveness plane with the 4 quadrants, and you can see that this one it's bordering 2 of the quadrants, and that top left one is really, from the point of view of actually getting that intervention implemented, that's where it doesn't want to be, because that's more costly and less effective. So it's almost 50-50 as to whether it's more costly and less effective, or more costly and more effective. And you can see that that's sort of 50-50, as I say, and that line that's cutting through it, that's the threshold line. So anything below it, or perhaps in this case better to think of it as to the right of it, is cost effective. Anything to the left of it isn't. So I think you can probably just about see in that diagram that there's more to the left of the line than there is to the right, so it's probably not cost effective overall. It's probably got about a 57% chance of not being cost effective, I would guesstimate. And yeah, I suppose to go back on something that I said right at the start, in terms of why cost utility analysis is useful. I mean, it's useful for a lot of ways, but hopefully I've partly explained why that uniform measure of effectiveness is very useful. But the other thing it's very useful for is actually fully representing uncertainty. Because when you decide that you're just going to look at, say, a cost minimization analysis and assume that things are equally equivalent, that actually wouldn't give you the opportunity to actually assess the uncertainty around that assumption. You're kind of cutting off the variance on the effectiveness side of things, so that in this case you wouldn't have that spread from left to right. You would just have the y-axis. You just have the costs. That's the only thing you're considering. You're not considering both aspects. So yeah, I think that's the last slide. So just thank you very much for your time. It's a new experience to give a presentation like this virtually, but it's very much appreciated. And if you'd like to contact us, our contact details are on that slide there. And I think we're going to take any questions. So yes, thank you very much for joining us. And Dewi, I think it's back over to you.
Can you hear me okay, Matthew?
I can.
Wonderful. So thank you very much for that. We've had a handful of questions come in, which is great. And as I mentioned at the start, we're going to prioritize those that have received the most thumbs up. So the first question is from Mohammed, and I can answer that. So that is asking whether we'll be able to share the slides after the event. The quick and simple answer is yes, we can. I'll arrange that to be circulated via the Life Sciences Hub team who are organising this week. The next question after that, Matthew, is from Saran, who has asked, could you please share how you determine the quality of life score for patients with disabilities?
Yeah, absolutely. So it would be using, for a health economist, again, it would be using a generic measure. So regardless of what the disease area is, we'd be relying on that EQ5D as our best estimate of quality of life. So one of the domains within the quality of life EQ5D measure is mobility. So I guess you'd expect to see perhaps some impairment in mobility that's going to lead to some lower quality of life. You might also get some pain and discomfort. So yeah, broadly speaking, regardless of the disease type, we'll be looking at EQ5D as our measurement of quality of life.
Thank you. So our next question is asking, I suppose, yeah, is asking, would you look at areas where commission services which are not cost effective and that we probably need to cease? So essentially, do we look at technologies that need disinvestment?
Yes, we definitely do. Health Technology Wales has it specifically mentioned within its remit to look at technologies where we should be disinvesting. So yeah, that's absolutely something that we cover. I don't know that we've had. I don't know if we actually made any specifically for disinvestment. Off the top of my head, I can't think of any, but it's definitely within our remit, and we would do it if we found something of that nature.
The next question is from Nick, who has asked, how would you apply these practices to software used in the NHS?
Well, at the risk of giving a woolly answer, I guess it would depend on what the software is doing, but the principles are the same, regardless of what the technology is really. I mean, there's certain things you have to think about with digital technologies, digital interventions. NICE, for instance, has a set of evidence standards for digital technologies, which lists out what sort of things you need to prove in order for it to sort of prove that you have a decent level of evidence for that digital technology. But in terms of the HE elements, it doesn't really change things massively. We'd be looking at it the same way, again trying to link it to patient outcomes. So it does, I guess you could argue what it does do, depending on what you were talking about there when you talk about digital interventions. If it's something that doesn't have that direct impact on a patient, then it gets tricky. So for instance, a kind of broader waiting list management software, something like that, something that's going to maybe affect how easily patients could get booked in, that might be quite tricky to actually do a full cost effectiveness analysis on. But other types of things that are digital apps, pretty straightforward for the most part, as long as there's evidence. I mean, that's the key to all of it really, is getting that evidence so that you can link outcomes to outcomes that matter to patients, which is survival and quality of life ultimately.
Matthew, you've referenced NICE there, and Alex has asked, and it's a bit more of a general question rather than a health economics question, but Alex has asked, could NICE accredited technologies be introduced through Health Technology Wales? And do you want to explain the relationship between Health Technology Wales and NICE there?
Yeah, certainly. So in terms of things that are already recommended by NICE, I presume that's say NICE accredited. I presume that's what you mean. So things that are already NICE have recommended that something should be used. That we don't tend to cover things in Health Technology Wales that NICE have already looked at, because really we're not in the business of duplicating something that they've already looked at. If they recommended that something should be used, then that tends to get picked up in NHS Wales, or it should do. So it should be getting picked up, and so our assumption would be that that's already happening in Wales. We are actually, as part of our remit, that adoption side of things. So I briefly said at the start that we've got these three domains: is identify, appraisal, and adoption. Part of the adoption and aspect of that is auditing to see whether people are actually adopting the recommendations, and not only our recommendations but NICE's recommendations too. So we would be checking that in future as to whether NICE recommendations are being picked up in NHS Wales, but that's certainly our assumption that they are. In
that answer, I think you've probably answered the question of why would Health Technology Wales deviate from NICE guidelines there. So I'll move on to our final question, which is from Julie, which asks, how would you begin, and it's quite a specific question, how would you begin to run an analysis on cost effectiveness for telemedicine or a virtual consultation?
Where again, it would probably, it's quite specific, but possibly not specific enough for a health economist, in that it would depend what the telemedicine is, what it's doing. And so say a virtual consultation, you may be able to, obviously there's going to be cost savings, or we could make the assumption that it's going to be cheaper to see the GP or something virtually than it is in person. So it's probably going to be cheaper that way. So there's probably some immediate economic benefits in that sense, that it's going to be a bit cheaper. It may also mean that a patient is able to get seen when they otherwise wouldn't. So again, if there was evidence that you were able to link that to some sort of improvements in patient management, that would be the key thing, really. It's getting that link to patient management. That's always the focus. So yeah, so I'm trying to think of a good example, because I think we've had one recently about blood pressure monitoring with a telemedicine component, and that might you might be able to say in that case that actually having that blood pressure monitoring done that way means that you've got your blood pressure under control, less likely to have some sort of nasty event. But again, it's getting that evidence to actually demonstrate that.
Wonderful. So I'll take us to our last question from Scott Bevan, which is asked, does the threshold potentially give suppliers an incentive to charge more for a product as long as it's under the £20,000 per QALY threshold, even though the product could have cost less?
In short, yes. Yes, it definitely does do that. Yeah, I mean, I think there's definitely a possibility of fixing prices based on the knowledge of that threshold. Before working for Health Technology Wales, I worked for a consultancy, and where we worked for pharmaceutical companies and medical device producers, and that was something that was increasingly looked at. It's not massively easy to do, in a sense that they have to be pretty confident about their QALY estimate, if done in a kind of unbiased way, because you'd have to know that to be able to estimate your own cost, to be able to come out with a value that's roughly 20,000. But it's certainly something I think, to be fair, that they do. They do sometimes do that.
We've had a couple of questions in that ask whether the session is being recorded. I'm informed that it is. I don't know how it's going to be circulated, but I will ensure that it is, and everyone who's with us and registered for today, that will be communicated with you. And thanks again, Matthew. I think that's for all the questions we've got time for. I wondered if we may very briefly, if we may highlight any particular on the Health Technology Wales website of evidence appraisal reports or guidance that people could visit and see some of the principles you've talked today that have been applied.
Yeah, absolutely. So I think a couple where we've gone into more detail on the economics, but obviously it's not always possible for everything you appraise to go into full economic modelling. But those where there was one on Synovial, which is a test for periprosthetic joint infection. There's also one on that I've mentioned a couple of times in the slides, was autologous hematopoietic stem cell transplantation. Bit of a mouthful, but for MS, that's got a very full economic evaluation as well, which is worth looking at.
Wonderful, thank you very much. So for any questions that have gone unanswered, we'll answer those probably via email, and we'll make sure that that's circulated to all recipients, so you can all see all the questions from today. At the just a reminder that at the end of this week, the Life Sciences Hub will also circulate a feedback form. We'd really welcome your honest opinions on today's session to help us improve these webinars for future attendees, and potentially for yourselves as well, if we did run a Health Economics 102 or an advanced sequel to today's presentation. And before we depart, it's just a reminder for anyone who isn't already registered, Health Technology Wales are back on Wednesday afternoon at 3 o'clock for Health Technology Assessment 101. You can find full registration details, I should say, on the events section of the Life Sciences Hub Wales's website. There's 21 other sessions as well running this week still to go. You can see the details on the Life Sciences Hub website. Very wide range. I'd recommend you taking a look at those, and make sure to check out the Health Technology Wales website too. The website for that is healthtechnology.wales. Sorry, the URL for that website is www.healthtechnology.wales. On there you can find all of our reports and guidance. You can sign up to our e-newsletters. You can find out more information about our scientific advice service, which launched last week and is aimed to help health technology developers optimize their plans and route to market. That concludes today's webinar. Once again, thank you for joining us, and we hope to see you again soon.